they'll take care of carries out into adulthood. Oops. Oh, okay, sorry. So just a little overview of our talk today. I'll go over some of the clinical manifestations of eustachian tube dysfunction and how they present in childhood and onward. And then we'll go over some stepwise interventions for children specifically, but a lot of this is applicable to the adult population as well, both for sort of early manifestations and then later sequelae of eustachian tube dysfunction. We'll talk a little bit about timing, tips, and pitfalls, and then I'd love to open it up to discussions and questions. This is, a pretty challenging problem that we all deal with, and I'm, as Richard mentioned, pretty new in my practice. So I'm definitely, I think, on the one hand, I'll give some tips from the vantage point of somebody who's sort of still pretty green at ear surgery, but my fellowship did a large portion of ear surgery, so I think I've picked up some interesting things from all the different people I've worked with over the years. And then I'd love to kind of hear everybody's input and other ways that maybe things y'all have managed eustachian tube dysfunction if I don't mention it. So first, just a little bit on pathophysiology and differences in kids and adults. As we all know, the eustachian tube in kids is more in a horizontal plane, so it doesn't drain quite as readily, but in addition, it's more narrow. The cartilage in kids is more soft and pliable, so it's easily collapsible. And then kids also, of course, have large adenoid pads, which can lead to obstruction, as well as be a potential nidus for chronic infection for some of the sequelae of eustachian tube dysfunction that we see. Overall, there's been a number of people who have tried to study sort of what the mechanisms of eustachian tube dysfunction are, and it's sort of rooted in poor ventilation from blockages in the eustachian tube, but this creates a negative pressure in the middle ear space, and over time, as the tympanic membrane collapses down on the middle ear structures, it can impair mucociliary clearance. This plus the obstruction can cause a chronic effusion that has a lot of inflammatory mediators in it, and due to an inflammatory response, there are actually structural changes in the TM that weaken it over time. There's also erosion of the bony structures from all of these processes, as well as collection of keratin and the possibility of cholesteatoma from all of these mechanisms. So we'll kind of go into a little more of this and how it applies clinically and surgically. So in terms of early manifestations of eustachian tube dysfunction, of course, recurrent persistent otitis media or acute otitis media in children is a very common problem, and one that can result in costs related to missed school and work. There's a lot of concerns about antibiotic overuse, especially when prescribed by non-ENT providers, and a number of suppurative complications of acute otitis media. So tympanic membrane perforations, mastoiditis, things that we've all kind of encountered in our practice, really. And then, with this, the development of chronic otitis media with effusion is among the most common pathologies in children. Hearing loss due to this issue can have impacts on their sort of social development, behavioral and attention, hyperactivity has been linked to even mild hearing loss in children, cognitive development, speech and language to some degree, as well as some vestibular issues, which often in kids is not even really recognized because they can't tell you that they're dizzy, but there have been studies looking at motor dysfunction and imbalance in kids related to effusion. So in the United States, grommets are the most common surgery that we perform. There's over 600,000 done a year, and there's been a number of, in recent years, there's guidelines that have been put out to help guide when and how we decide to place tympanostomy tubes or grommets in children. So just to kind of show a couple slides on hearing loss due to this problem, this on the right is a sort of a typical audiogram showing a conductive hearing loss. And on the left, you can see that there's really a spectrum in how bad an effusion can affect hearing. I mean, sometimes it doesn't cause any issue at all. But you know, and I've seen this in my practice, it's even just a normal effusion can cause quite a significant hearing loss, to the point that children are really not hearing even normal speech. So some of the late manifestations of eustachian tube dysfunction, as you've all probably encountered, this can happen on a real spectrum of severity. On the sort of lower end, things like laryngosclerosis from chronic infection, as well as the placement of PE tubes down in the left. This lower photo here is showing a drum that has some pretty significant laryngosclerosis, which, you know, if it involves enough of the drum, it can cause some issues with conductive hearing loss. Recurrent perforations that are tricky to repair. Retraction pockets are quite common. It's in this the photo on the right here. We're looking at an attic. The malleus is here, and then we have the attic showing either wax or keratin debris that's pulling into that and potentially forming a cholesteatoma over time. You can get middle ear adhesions that can cause conductive hearing loss, tympanic membrane atelectasis, vesicular erosion, and of course cholesteatoma. Here's a couple more photos. On the left-hand side, we have a completely adhesive atelectatic eardrum. You can see the promontory, as well as the malleus. Sometimes the malleus gets over-rotated with this process. And you can actually see the IS joint here. Can you guys see my mouse?
Yes.
Okay, great. On the right-hand side, we have, again, a pretty major retraction of the pars tensa. And you can see here that the incus has actually been eroded away. We're looking right at the stapes capitulum. Down here is the promontory and the round window, which is, you know, you can see the skin from the drum almost tracking down towards it. This is, you know, likely sort of comparable to a type 3 tympanoplasty. I don't know what this person's hearing is like, but there's a potential that the hearing is actually, you know, quite preserved with this. But still, it's a very abnormal looking eardrum, and the need to sort of observe and follow these patients is really paramount, because you can end up with cholesteatoma tracking into the sinus tympani, especially as when you see the incus eroded, it gives a sort of a window for skin to track posteriorly into places that are potentially quite problematic. So in terms of our interventions for this problem, of course, tympanostomy tube or grommet placement, as I mentioned, is quite common. In 2013, our American Academy put out practice guidelines. And in terms of the guidelines for chronic otitis media with effusion, the sort of standard to place tubes is having persistent otitis media with effusion over a 3-month period, so 2 documented exams showing effusion, or an audiogram if that's feasible, with conductive hearing loss showing a type B tympanogram. There's also other validated hearing assessments, including questionnaires for parents with some, you know, questions related to a child's ability to hear and communicate. So using kind of these two pieces of diagnostic information in conjunction, that's sort of our threshold for placing tubes. Of course, also recurrent otitis, acute otitis media, especially with documented effusion, or concern about kids who are at increased risk for negative sequelae, kids who have had a number of infections over the course of the year, usually more than 3 and 6 months, are often candidates for this. For kids who, you know, there are parents who elect not to have it. We'll talk a little bit about the complications of this quite common surgery. But reevaluation every 3 to 6 months for persistent or developmental or developing hearing loss and other sequelae that, you know, we mentioned is quite important. But, you know, there is a number of patients that resolve, obviously, without intervention. So there's a number of tympanostomy tubes. This one on the right is a T-tube, and I'll talk more about this in conjunction with other ear surgeries that we do. But these are generally, you know, reserved for recurrent chronic otitis media. And then on the left-hand side, this is showing sort of one of our typical grommets that, you know, it's placed in the inferior anterior quadrant of the eardrum. There's also much smaller ones for children with stenotic ear canals, and a whole variety of different products out there. So some of the just simple considerations and complications that we see with tympanostomy tube placement, things that are common and usually not problematic include tube otorrhea. One of the things, of course, that we're treating is effusion and recurrent infection. So having the tube allows us a way of treating with drops as opposed to systemic antibiotics. Focal atrophy of the TM with the monomer, which oftentimes can be mistaken for a perforation, and small areas of meringosclerosis, generally don't cause problems. But things that are potentially problematic are persistent perforations, which occur in about 2% of patients, granulation tissue or obstruction of the tube, as well as the tube just as a nidus of infection if it's in there long enough and kind of having a lot of junky granulation blocking it. It can cause sort of ongoing chronic otorrhea. A retained tube and a medialized tube is potentials that can cause issues, and chronic perforations, things like that. Of course, kids oftentimes undergo anesthesia for this, for placement of tubes, and that's not without risks. And then for some patients, the need for follow-up and it kind of needs to be weighed against the cost of how big of a debilitating problem their otitis media with effusion or acute otitis media really is. So in terms of other sort of stepwise treatment for this problem, in the mild to moderate range of what this disease can do, I think replacement of grommets is quite common. For kids that are older, over the age of about 4, we start thinking about T-tube placement, potentially even earlier if kids have issues with extrusion that happens early. That's another potential sort of consideration for the T-tubes. Adenoid surgery is quite effective for this problem in patients over 4, less so under 4, but there's pretty significant data in a Cochrane review that look at adenoid surgery. So when we have kids who have had tubes and are coming in after the age of 4, even in the absence of other OSA type symptoms, we're often performing isolated adenoid surgery for the treatment of otitis media. And then eustachian tube dilation, there's quite a bit of data on the adult population showing that there's some efficacy of this procedure. This is a depiction of what this looks like. And there's a recent study on I think a few hundred kids out of Europe that are showing sort of some data on safety and efficacy in children. So we've started doing this as well. The balloon is placed through the sinus, or through the nasal cavity and into the eustachian tube, and it really only impacts the cartilaginous eustachian tube. The prevailing thought behind it is that it breaks up adhesions that are sort of within that cartilaginous portion, and by stenting those open, you're allowing improved drainage. In terms of safety and concerns, I think there's some concern about can this device cause a carotid injury? So a lot of people are getting CT scans, and that's precluding a lot of people from wanting to do it on children. But in theory, generally speaking, the carotid canal, it should not be near or at risk the cartilaginous eustachian tube. So that's something that's sort of coming down the pipeline. In terms of ear surgery for some of the late sequelae of eustachian tube dysfunction, there's many approaches to a very challenging problem with this. I think one of the biggest things is just decision to operate is really on a case-by-case basis, and observation is often the best option. So, when do we intervene? And it's really like anything else, if we have cholesteatoma that's really causing problems, and such as progressive hearing loss or other concerns about erosion into vital structures, then we have to think about it. But if it's possible to wait until a child has outgrown eustachian tube dysfunction on the contralateral ear, so doing a contralateral exam to examine what the eardrum looks like to see if it's aerated is always a decent problem, especially if it's for hearing specifically. If a child has access to hearing aids, you know, there's some reasonable option to aid them, and then if they want surgery later, you know, provide that as an option, since this is rather challenging. So in terms of techniques for approaching this problem, sometimes even just insufflating atelectasis during anesthesia can you know, put air into the middle ear space. Then you're able to place a T-tube, and sometimes that's adequate and provides pretty good hearing outcomes. For shallow retractions without extensive cholesteatoma, transcanal endoscopic surgery is a great option. If any of you were tuned into Dr. Wilkerson's lecture last year, even with a 0-degree scope, you can see pretty, you know, a pretty wide field of view, and with retractions that go up into the attic, epitympanum area, and even into the sinus tympani, you can see quite a bit. And if it's not extensively tracking into, you know, into epitympanum or into the mastoid, then this is a decent option to perform surgery on these patients. And you know, if it's really extensive, or if the retraction goes deep into the mastoid, or if there's cholesteatoma, you know, that's kind of collecting to the reaches of your endoscopic equipment, then converting to an open procedure is definitely something that should be planned for. Cartilage grafting is something that some people, you know, utilize for this problem. In kids, I'd say it's not necessarily first line. I think, you know, maybe one of the differences in my thinking when I'm operating on children is just that they have a lot longer potentially in life to live, and their chance for recurrence is a bit higher just through longevity. So because of potential problems around cartilage grafting, it wouldn't necessarily be the first thing that I would do. However, I think it's a good technique to overview, and I just wanted to show a quick video.
Excuse me, Lia.
Yes.
What would you use as graft in children if you don't really like cartilage?
Yeah, so actually, especially with transcanal surgery, I've been using a lot of Biodesign this year, which is an allograft. And I was trained prior, you know, harvesting either tracheal cartilage or temporalis fascia, both of which are easy enough to do. But if you're not making an incision, the Biodesign does pretty well. I would say, before I show the cartilage video, let me just go back to this and kind of elaborate on that a little bit. Can you guys see my PowerPoint?
Yes. Yes, okay. Yes.
Yeah, so one thing I would say is if you are doing a graft without cartilage, you know, either a fascial graft, perichondrium, or a you know, a biosynthetic material, placement of a T-tube at the time of tympanoplasty is a nice adjunct. I'd say, you know, if you're doing, say, correcting an attic retraction, and it's not too severe, you know, in an adult, you might do this really wide takedown of the scutum. And if you need to do that to get to the cholesteatoma, then you definitely should do that. But if it's, you know, if it's reasonably small, placing a you know, a graft without cartilage with a T-tube and angling the flange of the T-tube towards the area of retraction is one sort of option you might have to try and avoid using a cartilage graft. In terms of issues with cartilage grafts, you know, I think there's a chance of having a recurrent retraction around the graft, and then you're having, you know, you have a very small area of retraction that can hide cholesteatoma and collect a big keratin pocket underneath the graft, and it's a little harder to assess. So that's one of the reasons that, you know, we may avoid it as a first line issue, as a first line surgery. I think, you know, the thickness of the graft is important. If it's too thick, it can limit your you know, sound conduction. And then I've had issues with both with OCR and with cartilage grafting, taking kids back. Sometimes with bony regrowth in kids, they tend to you know, they have a pretty high rate of neoosteogenesis. So you can have, even if you place a cartilage graft in a off of bone of either the EAC or maybe adjacent to the scutum. I've had them actually adhere to the scutum, and you can really see that the bone has regrown, and then it causes issues with conductive loss. And whether you're doing an OCR or a graft, sometimes that can be something that you can see on a second look surgery. So I think these are just a couple things to keep in mind. Let me see if I can get this video to show. Oh. So this is, let me just skip ahead here a little bit. I think I just wanted to show a little bit of placement of a cartilage graft in the epitympanum. This is, takedown of the scutum.
We're still on the slide, Leah.
Oh, you are? I'm sorry. Are you?
Okay, we're good now.
What are you seeing? Okay, great. So yeah, that was just taking down scutum.
So this is a right ear taking down the scutum. Okay.
Yeah. Yeah, and this is an endoscopic
There's a view there.
Yeah. I think what this does a nice job, they're going to dissect it off malleus, and then, the retraction pockets can oftentimes go in anterior to malleus around the cog. So coming around and really taking it down is sometimes pretty critical to actually getting the entire retraction pocket out. And what I was saying about a T-tube is, if you can imagine, if you place the T-tube in the anterior, quadrant to some degree, just like you normally would, those flanges are pretty long, and you can sometimes just sort of maneuver them to get them up underneath ossicle. And, I think the thing is, like, you can have an aerated, a partially aerated ear, but if you try and fix one of these without aerating the portion that had retracted, then you'll end up with a recurrent perf. So utilizing a T-tube for that reason. I'd be curious to hear if that's something people are doing more with adults as well, or if because we place a lot of T-tubes, it's just one of our go-tos. But we've had pretty good results with that. So yeah, then they're just using their round knife to measure what the defect size is, and then packing with gel foam.
What you can also do is you can put a piece of cartilage. Okay, there you go. Okay. Yeah. You've got to put cartilage there to prevent further retraction. Granted, this patient has eustachian tube dysfunction. You've got to support the graft where the retraction was, and cartilage is the optimal material for this.
Yeah. And harvesting a piece of tragal cartilage is, it's pretty fast and easy to do. You can take the perichondrium off of both sides and even create like an island of cartilage in the middle, and then use perichondrium to sort of tuck underneath, or tuck underneath your skin flap. Okay. So yeah, this is just a T-tube shown being placed during surgery. It's a little bit hard to tell what you're looking at there, but I've placed them both in graft material and in the native TM. It's a little bit challenging because everything is sort of floppy, but it's something that can be done during surgery and provide aeration if you're concerned. And then I haven't gotten into the practice of doing dilation, like a eustachian tube dilation during the bigger ear surgery, but it's something I think I might try to incorporate more, especially as we, kind of just to see. I think the jury's still out on how effective it is, and if any of you have incorporated this into your practice, I'd be interested to hear about it. But even just doing an adenoidectomy is kind of a nice adjunct when you start, seeing kids or who have this problem. I think in the adult population, obviously, it's less likely that they're going to be having issues with adenoids as sort of an ongoing issue. But yeah, that was kind of my presentation for the day. That was actually a lot faster than I anticipated. But do you guys have any questions or other sort of experiences to share?
Lia, I think
Yep.
that, let me start this off. I think it's really important. It's really important for everybody to understand that eustachian tube dysfunction, from an academic point of view, is the root for most ear disease. Okay, when we talk about atelectatic drum, when we talk about retraction pockets, when we talk about formation of cholesteatoma, these are attributed, other than for congenital cholesteatoma, attributed to eustachian tube dysfunction. Now, we do a tympanoplasty, or we do a mastoidectomy with ossicular chain reconstruction. Do we go assess the function or patency of the eustachian tube? The answer is, I always look at the eustachian tube under the microscope, but I can't tell if it's, unless there's a massive amount of granulation tissue or it's completely scarred over from a chronic otitis media, we really can't tell whether or not it's open and functional. If you're doing surgery under local anesthesia, you could ask the patient to, plug their nose and Valsalva, and you'll get air coming into the middle ear. But again, we don't do this. The real thing is that we're going to do the surgery that we planned. If we've got chronic thickened middle ear mucosa versus normal healthy middle ear mucosa, we're still going to do our tympanoplasty. You might use cartilage support in the chronic stage of mucosal thickening of the middle ear. But if I've got a nice clean perforation, normal appearing middle ear mucosa, I'm not going to put cartilage in. I'm not going to do anything other than a straight, fascia or perichondrium tympanoplasty, maybe biodesign. But I think it's always, we always talk about eustachian tube dysfunction, but we don't really address it from a surgical point of view when we're doing middle ear surgery. So I just kind of wanted to bring that home. The other thing is, Lia, what do you recommend about swimming? Children who have a grommet. Grommet is a pressure equalization tube. Depends what country you come from. Okay. When I lived in New Zealand, they used the word grommet. We use PE tubes in America, but it's one and the same. So Lia, tell us what your recommendation is as a pediatric otolaryngologist when the mother comes and says, okay, you put tubes in my kid's ears, but we want, Junior needs to learn how to swim. Okay.
Yeah. So actually that's actually part of the guideline recommendations, that we don't prohibit kids from swimming. It's pretty low. There's pretty low rates of otitis media and externa from swimming with ear tubes. So there's some data out there to suggest that dunking your head in a bathtub with soap is actually worse because of the viscosity of the water. It can get into the middle ear space a little easier, but routine swimming, unless it's somewhere where there's a lot of pollutants in the water, is not prohibited. So yeah, I haven't had a lot of kids have issues with that at all.
Okay, there's a question here from Kartik. It says, do you address the tensor fold if it's complete in cases of isolated attic retraction, suggested of selective dysventilation?
So, I mean, I think and Richard, jump in on this as well. I mean, I think my approach is really to make sure that the retraction, if I'm going to be addressing it, you're really scooping out the entire retraction. I think.
Let me
Yeah.
help you here. Dr. Wilkinson talked last week about endoscopic ear surgery. Now, obviously, your tensor fold in a case where it's visual and you're doing a endoscopic approach, if you can take the tensor fold down and you feel it's inhibiting adequate ventilation and there's a blockage, you can do it. But most of the time, we're really not paying attention to this, to the tensor fold, especially in chronic ear disease, because it's already been destroyed. It's not something we're going to identify. So I think what's more important, unless you're doing endoscopic ear surgery and you have perfect visualization of this structure and you need to remove it, the answer is no. Okay, so the answer is no. The other thing is, don't forget that, placing a grommet ventilation tube is not a free ride. 2% of the children get perforations. And another question we have to ask ourselves is, okay, we've got a kid, he required a ventilation tube. When do we repair the perforation? Okay, when do we repair the perforation? Because really, the skull base and the Eustachian tube angle is really not fully developed almost until about the age of 9 or 10.
Yeah.
And yet we've got kids that are susceptible to chronic upper respiratory infections. So based on chronic respiratory infections and continued development of the skull base and the Eustachian tube, Lia, what has been your training in terms of post-operative perforation from a grommet? When do you go back and do a tympanoplasty?
Yeah, it's exactly as you said, Richard. I mean, generally we're not touching those until at least age 10. And I mean, the majority of time, they're not really causing problems, maybe a mild conductive loss, but if they're small perforations, like the size of the tube itself, then they're really not causing much issue other than maybe some, like persistent or recurrent drainage related to the fact that the kid's having URIs and potential ear infections that are just auto draining through the hole. So I mentioned it in one of my slides, but looking on the other side of the ear, on the other ear before deciding on repairing a perf is always a good practice in kids, because it can help you kind of guide when just kind of clinically how the drum on the other side is looking. Of course, a tympanogram also can give you that information. So that can help manage when timing wise. But I would say about age 10, that's when, as you said, the Eustachian tube tends to take that more downward trajectory.
The other thing is, I've noticed, having traveled to essentially every continent other than the Middle East, that grommets are not a common available treatment modality in many countries. Okay. Ukraine, I have yet to see anybody put a grommet in. I've yet to see anybody talk about grommet placement. Ethiopia, probably can't answer that. I've been there 10 times, but it's always been for chronic ear surgery where, it's way late for any kind of grommet. New Zealand, where I lived for a year, there was an incidence of 15 in school-age children under the age of 5. The incidence of otitis media was above 15%, which is huge. Okay. The whole Pacific Ocean, the Pacific Rim area has huge amounts of otitis media. And yet we're not seeing grommet placement in a lot of these nations, micronations, I think you might want to call them. The other comment, and then we have a few questions, is use of biodesign. I've used biodesign not only for tympanoplasty and canal wall down procedures, but I've also used it as a graft for stapes surgery. Tell us, biodesign is made from, I think, cow intestine, and it's really biocompatible. Well, tell us what your experience is with biodesign and whether or not you like it or not.
Yeah, it's actually fantastic. I trained in a place that did not use these kind of materials, and I don't know much about the cost of them, honestly. I haven't done a deep dive into that. But in terms of our outcomes, kids do really well with them. I mean, I think it's certainly no worse than autologous graft material. And yeah, so we're seeing really good results. And I haven't done a lateral graft tympanoplasty with it, mainly because I've been going post-auricular, and so the fascia's right there. But for medial grafts and grafts up into the epitympanum, I've used it for a variety of repairs, and I haven't had a lot of issue with them. So I personally like it. It's quite easy to use too, in terms of its just the sort of pliability of the material. And you can cut it to size. It comes in little squares. And
yeah, no, it's readily available, easy to use, cut your surgery time down tremendously. Yeah. Unfortunately, it's like fairly expensive. Tracheoperichondrium, if you need a small piece, is probably just as easy to get. It's easy to get, it's affordable, so forth and so on. Okay, so Nestor, apparently you have a question. Please turn your microphone on, and we'd like to hear what you have to say.
Hi, Richard. Well, I would like to know if you use any medical treatment to treat Eustachian tube dysfunction. We know that most of them are not, they don't have very good results.
Yeah.
But if you read the guidelines, they say that you have to wait at least like 2 or 3 months before you place the T-tubes. Once you have diagnostic the otitis, serous otitis media.
Right.
So what do you do? Can you do something before you place a tube? That's my question.
Yeah, that's a good question. I mean, part of it is, so some things we tell adults with Eustachian tube dysfunction are things like trialing Flonase, saline irrigation. You could try a brief trial of Afrin, like oxymetazoline, to try and pop open the Eustachian tube from the other side. Kids, it's hard to get them to put those kind of medications up their nose, for one thing, and two, the efficacy is not great. We do sometimes trial montelukast for adenoid and tonsillar hypertrophy in kids, more so I'd say for the treatment of like sleep disordered breathing or OSA, for parents that are not apt to go right to surgery and do want to trial medical management. So in theory, those have some effect in reducing the size of like adenoid tissue, but it's not. I don't think it's a great option, and I think the reason to wait, Nestor, is that it can be a transient problem. So in an effort to not to not put in more tubes than we're already putting in, and we do quite a few in this country. I think Richard made the point that they're not without risk. I've seen kids who really do have a lot of chronic problems with granulation and otorrhea, and they're just, they're really kind of unhappy with the tubes themselves. So it's, while I think they're really helpful, in a big majority of kids, it's, I think that's sort of one of the reasons we do give it time and we wait, at least, to get subsequent ear exams to see if there's effusion that lasts over time.
Okay, because sometimes we know that we had to wait like 2 months or something before we do put the grommet or the tube, but sometimes it's better like for the parents to have something to do with their kids. Sometimes the parents are the ones that are very anxious because they know that their kids are not listening well.
Yeah.
And I don't know how to say it, but sometimes they believe that you are not doing a lot if you just wait. So you had to do then something to do in the meantime, perhaps.
Well,
Yeah.
there's that guy Rosenfeld, Rich Rosenfeld,
Hmm.
New York. Okay, and he says, you know what? Kids who get otitis media, treat them with, paracetamol, which is non-steroidal anti-inflammatory,
Okay.
and see what happens. Okay.
Yeah. I mean, that's true too. I mean, it's, a little bit of inflammation or anti-inflammation can go a long way. So it's not unreasonable to try that if you didn't want to jump to surgery right away. In kids that have major like adenoid problems too, like, keeping in mind that, so one of the studies, one of the big RCTs looking at adenoid surgery for this problem, a simple myringotomy at the time of adenoidectomy was, they were showing that was as effective in treating this problem as placing a tube. So if I think in countries, especially where grommets are, not available, assessing for adenoid hypertrophy is not a bad potential option. But yeah, I think if we're talking about kind of conservative medical management, then paracetamol is a reasonable option. Saline spray, if kids are willing, or something like Flonase or fluticasone, is safe in the pediatric population to try, to try and open up that Eustachian tube.
When I was doing TNAs, okay, before I got white hair, my approach was this, kids got first episode of otitis media, doesn't resolve with antibiotics or paracetamol. You know what? He's going to get a grommet. But I always checked the nasopharynx, always looked at the tonsil size. Okay. I'd usually go put my first set of grommets in. Second time around, if they've got the same issue, I would be much more aggressive in doing an adenoidectomy, not necessarily tonsillectomy unless the tonsils were kissing, but I would be aggressive, okay? And I believe that it really cut down on any further evolution of middle ear effusions. So I think we've got to remember that. The normal middle ear space has bacteria in it. Everybody's, yours, mine, and everybody who's got a normal ear, there's bacteria that are in the middle ear space. They're not pathogenic. It's when we're starting to get abnormal changes and we're starting to get bacteria from the nasopharynx that decide they need to colonize in the middle ear space, okay, or we have a perforation, or we have a person who's immunocompromised, a person who's a Down syndrome, that's when we're starting to get a different colonization of bacteria in the middle ear, and that's why we get otitis media with effusion and need to treat it. So I think it's really important to remember that. We've got 27 people. I'd like everybody to raise their hand and tell us whether or not you are putting grommets in your country, okay? Again, we have people from all over the world. We have Somaliland, we got India, we got Paraguay, Uruguay, we have Bolivia, Ukraine, Poland. Can you guys, there's a little tab next to your name and it says raise your hand, I believe. If you could raise your hand if you're putting grommets in your country for kids with otitis media. Okay, Nestor says he does in Paraguay. Okay, people are starting to raise their hands. There's only two people so far, three. Wait a minute, we got 1, 2, 3, 4. Oscar, you're telling us they put grommets in your country? I've never seen it, unless you're hallucinating again. 1, 2, 3, 4, 5. We got 5 people out of 27. Agata, do you put grommets in Poland?
Yes, we do.
Okay, you're supposed to raise your hand then in the little chat room. Okay.
Your real hand.
Okay, I can see. I should. If you don't, you should put it. Lavera, you're supposed to raise your hand. You live in Paraguay and you work with Nestor. He says you do. You're saying you don't. Neela, you put grommets in Neela? Yeah, go ahead, Nestor.
I had one last question.
Yeah, go ahead.
I would like to know if Lia could tell us if when she has to do tube placement, most of the patients, if she does adenoidectomy in most of the patients, or the placing a tube is a single procedure most of the time?
Yeah, Nestor, most of the time, for my first line is to place a tube. In older kids over the age of 4, if they've had a set of tubes already, then we're assessing for adenoid, adenoid contributions and doing an adenoidectomy. One of my colleagues who's gotten into the Eustachian tube dilation won't do that until after both of those things have happened. So it is really like a stepwise thing. But my first line is a tube first.
Thank you, Lia.
All right, Neela responded from India. She puts tubes in her country. Anybody else? Anybody have any further questions, comments? Please feel free to do so. I think that if there's nothing further, Lia, there's a American Academy guideline on the treatment of otitis media. Am I correct?
There is. So I am my last slide has some references on the first one is the clinical guidelines for anyone who's interested. And I can actually provide the hard copy to you, Richard. And then there's some other studies you're looking at.
Yeah, email me the clinical guideline and I'll stick it on the link. Okay, so everybody can have a copy of it.
Sure.
Okay. Yeah, Rosenfeld, by the way, was my junior resident. So I know him fairly well. Real great. Anybody have any further questions? Okay, well, if not, we're gonna end this session. I appreciate Lia taking the time to talk about something basic, but something that is really the nucleus of ear disease. We'll get those clinical guidelines sent to you on WhatsApp today. If anybody wants the recording of this, please let me know, and I will send you a Dropbox link to it. In the meantime, Lia, thank you. Have a good time in San Francisco over the next month on your vacation. And I appreciate your time, as I'm sure the other participants as well.
Thank you for the invite, Richard. It's an honor to talk to all of you.
All right. Thank you again.
Have a good day.
Okay.